Let me find this lecture here. Here we go. Sorry. One of the things that I was going to do is talk to you a little bit about the Florida ACC. First of all, thanks for having me. I will try to make this as interesting as possible because it's late and I know everybody wants to get out of here on a Saturday. So I'm not going to talk about the Florida ACC only because in the interest of time, but we're really doing a lot of terrific stuff. And if anybody is interested, I'm more than happy to talk to you about it. Thank you. So I'm just going to skip right through this stuff and get on with talking about novel anticoagulants. And we've heard a lot about atrial fibrillation. And so what I chose to do was not to specifically talk about the disease processes, but to more talk about the direct oral anticoagulants as they exist so that you can have more of a 50,000 foot view. These are my disclosures. The important thing to recognize is that warfarin was approved in 1954, okay? And after that, really for the next 55 years, we had nothing, right? There was really nothing. We had some Lovenox, we had heparin, we had this, we had that. But really, at the end of the day, we didn't have any oral anticoagulants approved until about 2010. When dabigatran was approved and then all the others got approved. And so the important thing to remember is we have this almost psychiatric need to check the INR, right? To like, I want to be able to monitor this. But think about it. We give aspirin for coronary disease. How many times do you do platelet function studies in somebody that you give aspirin to or somebody that you give ticagrelor? You don't do that. And the reason is because you give it and you know it works. It's the exact same things with the oral anticoagulant. So I think it's just important to remember that the reason we even care about checking our anticoagulant level is because we had to. For 55 years, we had no choice. As you can see, direct oral anticoagulant use has increased over time. Warfarin use really hasn't changed a whole ton over time, unfortunately. I think that things are going to change. We've now got, I think within the last 5 days or so, we had the ACC put out an update to the 2014 AFib guidelines that I think everybody now knows recommends DOACs as the first line therapy for atrial fibrillation for reduction of risk of stroke and systemic embolism in AFib. So I'm hoping that this curve, that the green line is going to start to fall and the red line is really going to go up. And I believe that because I really believe it is best for patient care. And the reason is because warfarin sucks, okay? It's a rotten drug. If I were to pick a pharmacokinetic profile for a drug that was the worst that it could be, it would be warfarin, okay? It starts slowly so that you can't treat patients who have acute problems, right? It then goes away slowly, right? So you have very little control over what's going on. You have to routinely monitor the blood. Why? Because you've got these wide varying ranges of therapeutic efficacy with different dosages. You got some patients on 1 milligram of warfarin a day, and you got some people on 15 milligrams of warfarin a day. The drug interacts with everything. It interacts with air, for God's sakes. It interacts with food, every single drug. It's completely unpredictable. It's teratogenic. And even some people are like all fired up about how they can reverse it with vitamin K. Well, wait a couple of months. I mean, honestly, I think President Trump is deciding the wall is not being built because of warfarin. It's that bad, right? So in any case, not to say that a direct or, and by the way, I'm getting away from this term. I think we're all getting away from this term of novel anticoagulants. And for crying out loud, they're almost been around for 10 years. They're now, we consider them DOACs, or direct oral anticoagulants. And not that the directs really hit this list, but they hit it pretty darn well. The ideal anticoagulant would be fast, rapid onset, rapid offset, so you could use it in an acute situation, and you could take it off if you needed a patient to have a procedure and then put it back on so that it was reasonably easy to use, and you wouldn't have to bridge people. You wouldn't have to monitor it. You'd have no drug or diet interactions or interactions with organ dysfunction. You would have fixed doses, a predictable response. It would be safe in pregnancy and immediately reversible. The fact is that having a non-therapeutic INR is a really bad thing, right? So we all have people in our practice who have, who've been on warfarin for a long time, and every stinking time they come in, their INR is perfect, right? Yeah, we have those patients. Those are patients who are a reasonable candidate for warfarin. But I would submit to you that that's not a lot of people, right? And the other thing is, if you look at the time and therapeutic range for most of the trials that have looked at warfarin therapy, somewhere on the order of about 60 to 65% max. Okay, everybody thinks they're so great at managing warfarin. Even in the best of hands, under trial circumstances, 60 to 65% time in therapeutic range. And so what happens is you've got a group of people who are very high in their therapeutic range, 90 to 95%, and then you've got and that skews everything up to the 60 to 65. Then you've got a whole bunch of people who are in the therapeutic range 20 to 30% of the time. The reason you care is because if you look at the risk of an event, right, this line up here is if you're in the therapeutic range greater than 70% of the time. This line here is if you're in it less than 30% of the time. Guess what? This line here is if you're not even using it at all. Okay? So that tells me that there is significant risk to being a rotten warfarin candidate. Okay? And the reason is because you've got not only the risk of thrombosis, which if you don't use it, you've got the risk of thrombosis only, but here you've got the risk of thrombosis if you're too low, but you've also got the risk of bleeding if you're too high. You see what I'm saying? So the risk of not having an adequately controlled INR is real, and it's a problem. All right, so the DOAC profile, like I told you, is not perfect, but it's pretty darn good. It's predictable. You don't have drug or food interactions. You rapid on and offset, so you can use it in all kinds of situations. You don't have to monitor it. You've got distinctly less bleeding. We're going to talk about that. And now we've got effective reversal. What's the downside? Downside is cost. I think most of the insurance companies now are covering this, although quite honestly, it's the cost to you and me because we have to have a nurse practitioner or somebody do our pre-authorizations for these drugs. But at the end of the day, we can usually get them. It's not like it was, when these things were just approved in 2010. Valves are a distinct problem. If you miss a dose, of warfarin, you make it up tomorrow. What the heck, right? It's not that much is going to happen. But if you miss a dose of this drug, you actually are going to reduce your anticoagulant profile. And then even though you can't monitor, and that's a good thing, you can't monitor it, that can be a bad thing if you need to monitor it. All right, so how do these things work? Warfarin, we know, affects 2, 7, 9, 10, basically the factors that are vitamin K dependent. Dabigatran is really a direct thrombin inhibitor, so it affects right here, factor 2A, and the others are actually factor 10A inhibitors, so they directly affect factor 10A. So these are indications for oral anticoagulants. The only one that's appropriate for valves at this time is warfarin. They're all approved for non-valvular AFib and VTE treatment. And then for prevention of VTE, apixaban, warfarin, and rivaroxaban are for both hip and knee. Dabigatran is for hip only, and edoxaban is not approved for prophylaxis. So until we had the DOACs, we really, I'm saying we, when I say we, I'm basically saying me, I had no idea what the heck the P glycoprotein system was. I learned all about the cytochromes and the CYP3A4 and understanding metabolism, but until this came out, I really didn't know anything about the P glycoprotein system. So what it is it's another mechanism for metabolizing drugs that it turns out that these drugs happen to go through. What it is it's an efflux transporter. What it does is it sits in the gut, mainly is where it is, although it's in other areas, but what it does is it sits in the gut and it basically takes drug out of circulation and throws it into the gut. So the more active this drug effluxer is, the more drug gets eliminated in the gut and the more it gets essentially metabolized. Although it's not really metabolized, it's just eliminated, okay? So, that's right, this is not working. So basically something that, basically inhibits the P glycoprotein is going to stop this efflux out into the gut lumen. And so it's going to increase the concentration of the drug. And something that induces this P glycoprotein system, makes it more active, is going to increase elimination of the drug. And that's very important because if you look at your DOACs, every single one of them is affected by the P glycoprotein system. So strong inhibitors are going to increase your drug levels, make you more likely to bleed. And strong inducers are going to decrease your drug levels and make you more likely to have a stroke because you're not going to have enough drug around as you would expect, because it's another drug is inducing this efflux of the drug. And then these are also affected to some degree by the CYP3A4 system, so especially rivaroxaban, but also edoxaban and apixaban, which again, an inhibitor is going to increase the serum drug level, and an inducer will decrease the serum drug level, all right? So I have basically broken every single slide making rule by making this slide, okay? I understand you can't read it and it's a crappy slide. I get that, but I did it for a purpose, for two purposes really. Number one, if this was a warfarin lecture and warfarin was on there, I would have 8 pages practically of slides like this of all the interactions that it has, okay? But with this, there's really very little. The first line is the dabigatran. What you've got here, if you're looking at your inhibitor, your inhibitors are dronedarone and ketoconazole. That's it. And all you have to do is if the creatinine clearance is between 30 and 50, you reduce your dose to 75 milligrams BID. And as far as the inducers, the only thing that you really have to worry about is rifampin. Rifampin happens to be a problem with everything, okay? That's it. If you're looking at the factor 10A inhibitors, if you're looking at the inhibitors, what you're worried about is, again, ketoconazole and ritonavir. That's basically it. If you're worried about the inducers, it is Tegretol, so carbamazepine, the other anticonvulsant, dilantin or phenytoin, St. John's wort, and rifampin. So those are the drugs that you really need to know, not drugs that we usually use a lot. Ritonavir we probably use more than anything else, all right? But the others are not that problematic. All right, so we also have other drug interactions, is basically anything that is a blood thinner, right? So these are blood thinners, so they'll make you bleed, and anything else that you take that could thin your blood is a problem. So aspirin, nonsteroidals, etc. Not going to go through all these. SSRIs and SNRIs happen to have some modest antiplatelet effects, so they're on the list. And then, of course, any anticoagulant, direct thrombin inhibitors, thrombolytics, etc. No reason to read this. Okay, so what about monitoring this? Can't I just check an INR? Well, I can tell you that the surgeons and the ER doctors consistently check an INR. It makes no sense, people. There is no reason to do it, and there's no value in doing it. Again, this is a rotten slide, but I want to make the point that these are all the things that you can check. But just because you can check something and it's going to be abnormal if the patient's on the drug doesn't tell you that you're really getting any data that's of any value, right? So what you're actually getting is some of these drugs, or many of these drugs, actually interfere with the assay for PT-INR. So while you're checking an INR, all you're really getting is the fact that the INR assay has been screwed up by the drug. You're not actually getting a true evaluation of what is the level of anticoagulation of that particular person. So at the end of the day, what do we care about? What we care about is the amount of time that has passed since the patient last took the drug. So this comes into effect when we're interrupting DOACs for surgery. So the first thing that's really important, the ACC has come out and said basically bridging with a parenteral anticoagulant is not usually recommended in these patients because you don't really need to. It's very cumbersome to get them onto Lovenox and then off of Lovenox, on Lovenox, and on a DOAC. I mean, it doesn't make any sense. The pharmacokinetics are almost equivalent. For minor procedures, don't stop it. I had a guy come into my office 2 days ago, and this guy says, I'm going to get a deep cleaning of my teeth, and my dentist wants to stop my DOAC. I was like, that's ridiculous. You cannot possibly lead to death through your gums. It's not possible. Even if you're taking out a tooth, don't worry about it. Major procedures, of course, we recommend to stop it. Be very careful with any manipulation of the spine. So spinal puncture, they're doing an epidural. If the patient has spinal deformities, et cetera, you can get spinal hematomas. And so you really have to use high-risk recommendations for that. And then when you resume it, it's really important. Problem is that the surgeons don't get this drug. I still, 10 years later almost, I still get surgeons telling me, oh, if you're on Eliquis, you have to stop it 5 days prior to the surgery. You know what that tells me? That tells me is that if I want to hide something from you, I should publish it. Because quite honestly, you don't know what you're talking about. You do not need to stop these drugs 5 days in advance. That is not consistent with the pharmacokinetics. We're going to talk about how to stop these things. And when you resume them, the other thing is the surgeons are much more cavalier about resuming these things because they're used to warfarin that doesn't work for 2 or 3 days. These drugs will work within 1 to 2 hours. So you need to make sure you really do have hemostasis before you restart these drugs. All right, so interruption for surgery, basically apixaban and rivaroxaban have the same plan. What we do is it depends on the surgery or the risk of bleeding to the patient or the seriousness of the risk of bleeding. So I'll give you an example, neurosurgery. In that case, that's high risk. At least 48 hours is what the recommendation is. If it is, say, for example, a robotic hernia repair, robotic gallbladder, where a little bit of bleeding doesn't make a difference, and or the risk of bleeding is pretty low. In that case, 24 hours is fine. 24 hours is fine. All right? Because, and this is all published data. As far as dabigatran is different. It's based on creatinine clearance because dabigatran is very heavily cleared through the kidney. So if creatinine clearance is greater than 50, they say 1 to 2 days. If it's less than 50, it's 3 to 5 days. Edoxaban gives a very bizarre recommendation. It says, quote, at least 24 hours. I don't know what the heck that means. So, but in any case, that's the recommendation. All right. So what about dosing issues? I don't want to go through all of this stuff, but I want to make a couple of points, and this is in the interest of time because I know we're a little bit late today. But apixaban is only 27% cleared through the kidney, okay? So that it is very different than the other drugs. The other drugs all have creatinine clearance as their primary dosing strategy, whereas apixaban, because only 27% of it goes through the kidney, it actually has 3 things you have to look at. We call it the ABC. If you're age greater than or equal to 80, body weight less than or equal to 60 kilograms or 132 pounds, and creatinine, not clearance, creatinine greater than or equal to 1.5. If you have 2 of those or 3 of those, you reduce the dosage to 2.5 BID. As far as dabigatran, it's all on creatinine clearance, 75 BID if the creatinine clearance is 15 to 30, and it's contraindicated if less than 15. Edoxaban, this is the edoxaban Achilles heel. You can't use it in a completely normal creatinine clearance. That's the truth. If the creatinine clearance is greater than 95, contraindicated because it had too many strokes. It cleared the drug too quickly. 60 milligrams daily if it's 50 to 95, 30 if it's 15 to 50, and contraindicated if it's less than 15. Rivaroxaban, the cutoff down from 20 to 15 a day is if the creatinine clearance is 50. So what I would give you some practical pointers here is if somebody's creatinine clearance is, for example, 52, I wouldn't choose rivaroxaban because if they get a pneumonia and come into the hospital a little dehydrated and their creatinine clearance falls a little bit, they've hit that threshold. I would tend to use something like dabigatran, which they would have to have a real big hit on their kidneys, or something like apixaban, which has a different strategy. You see what I'm saying? So I try to stay away from the edges where somebody might tip over. All right. The other thing that's important to recognize is these 2 are actually FDA approved for use in dialysis. Now, it's important to understand that in the ROCKET-AF trial for this and in the Aristotle and the Averroes trial for this drug, they did not include patients on dialysis. So that is all done by pharmacokinetic modeling. So it is a little bit of a stretch to use them in dialysis, but they actually are and should be probably appropriate in that group. All right. What about DVT dosing? For apixaban, it's 10 milligrams BID for 7 days, and then 5 BID. For prophylaxis, it's 2.5 BID. And this is the interesting thing, again, because it's only cleared 27% through the kidney, you really don't have to do any renal adjustment. Dabigatran, for treatment, this is a little bit of a problem with this trial. It showed that you had to give a parenteral anticoagulant for 5 to 10 days. That was a study design, and not a great choice, because then you can give 150 BID of the dabigatran, and for prophylaxis, it's 220 milligrams daily, kind of an odd dose. But in any case, you can't use it if creatinine clearance is less than 30. Edoxaban does not have an indication for prophylaxis. Treatment only, again, this anticoagulant, parenteral anticoagulant for 5 to 10 days, and then 60 if it's creatinine clearance is above 50, 30 if it's between 15 and 50, and obviously don't use if it's below 15. And then with rivaroxaban, they're 15 BID for 21 days and then 20 milligrams daily. So these two drugs are actually very effective at treating people in the outpatient realm. You can actually, we've got people being sent out of the emergency room with DVTs. I mean, this was completely unheard of, several years ago. So this is terrific stuff. And then you go down to 20 milligrams daily. Prophylaxis is 10 milligrams daily. But again, don't use if creatinine clearance is less than 30. Hepatic issues. Very simple. I'm just going to summarize all this stuff mildly. If they've got mild hepatic impairment, don't worry about it. If it's moderate to severe, probably don't use it. Just doesn't make sense. Those are people who are at risk for some coagulopathies. Dabigatran has this very odd statement that you don't use it if the liver enzymes are more than 2 times the upper limits of normal, or if the hepatic disease is expected to affect survival. Not exactly sure what that is, but I think if they had moderate to severe impairment, I would not use it. All right, what about valves? All right, unfortunately, there was one trial, and this one trial scared the stink out of everybody from doing any further trials. I will tell you that there's now some basic science research that's bringing this back in a resurgence, but the Realign trial was done with dabigatran versus warfarin in patients who had mechanical valves, and it was designed as a phase 2 trial, right? It was supposed to have about 400 patients in it, and they had to stop it early after 252 patients because there were 9 strokes in the dabigatran arm with none in the warfarin arm. And on top of that, they had more bleeding. Pericardial bleeding was 4 versus 2 in the dabigatran versus warfarin. So they not only had worse strokes, worse clotting, but they had worse bleeding at the same time. That's the bifecta of a real disaster, right? So at the end of the day, it freaked everybody out. Basically, the FDA came out and said no DOACs in patients with mechanical valves. But from what I have seen, there is some basic science research looking at pig models with mechanical valves, and they're looking at using apixaban in that. So we'll have to stay tuned for that. All right, so what about bleeding? This is probably the biggest reason why we should be using these drugs, is the issues of bleeding. First of all, GI bleeding in general is about equivalent between warfarin and the DOACs, other than dabigatran, which for whatever reason, and it's not sure if it's the tartaric acid core or what the heck is going on with that, but they seem to have a 28 to 41% higher risk of GI bleeds than warfarin, and they're definitely, it definitely looks to be true, and was shown in the Rely trial to have higher GI bleeding. Intracranial hemorrhage, this is where we really win. We see about, on average, a 54% relative risk reduction in intracranial hemorrhage when we use DOACs as opposed to warfarin. This is huge. Blood in the head stinks, and this is a good reason to use these drugs. As far as total bleeding, it trends towards better depending on the trial you look at, but at the end of the day, it certainly does not trend towards worse. And in general, the anticoagulant activity is going to last for about 24 hours after the last dose. So if somebody comes in with bleeding, you can use prothrombin complex concentrate, activated PCCs, recombinant factors, but more importantly, at this point, we've really got reversal agents for everything. With dabigatran, we've got idarucizumab. Dabigatran is also dialyzable if it needs to be, but at this point, we've got a reversal agent, so there's no need to do that. For the factor 10As, we've got andexanet alpha, which has been approved and is now probably available at most hospitals, most large hospitals for sure. Apixaban, you can actually use activated charcoal. It will reduce your area under the curve, and it will also shorten your half-life by about 50%. All right, so the last thing I want to go over is some newer studies with the DOACs. I'm sure most of you have heard of the COMPASS trial. It was about 27,000 patients with atherosclerotic disease that was stable, and they were randomized. They all were getting aspirin, and they were randomized to actually an interesting dose, rivaroxaban 2.5 BID. Why they chose a BID dose in this in this particular trial, given that they kind of bill themselves as a once a day, I'm not sure, but that was the dose. And what it showed was a 34% relative risk reduction in the primary endpoint with an 18% reduction in mortality. It was pretty impressive data, but showed an increase in major bleeding. So what are we going to do with this? I'm not exactly sure. I'm waiting to sort of see. We're always dealing with this, yin and yang of bleeding and reduction in thrombotic events. I mean, if you look at the uptake of, say, the 60 milligram dose of ticagrelor from the Pegasus trial, it's not been spectacular, right? I think we're all concerned about increasing bleeding risk with, because if somebody bleeds, then we did it to them. If they have an event, well, we did the best we could. You know what I'm saying? So it's going to be interesting how this gets taken up. One of the big questions that we've always had is if you've got an unprovoked DVT, you have about a 5 to 7% increased risk every year of a recurrent DVT. So we've kind of never known what to do after 3 to 6 months of treatment for these DVTs. Well, Einstein Choice, Amplify EXT, and then a combination of the Remedy and Resonate trials basically gave us direction on what to do. Really, the right thing to do is to use low-dose DOACs for prophylaxis. It's effective, it's safe, and it doesn't cause a ton of bleeding, although it causes some, of course. As far as using DOACs during the period of cardioversion, we have Emanate, Expert, Ensure-AF, and then a sub-study of the RELY trial showing in all cases that this is safe and appropriate. And then finally, what do we do in cancer-associated DVTs? So cancer-associated DVTs are a problem because these people are very sick, and if their warfarin level goes down, they're very hypercoagulable. So the recommendations have been to use low molecular weight heparins, and there's actually been a lot of studies showing value to that. And so the ATOM VTE, the Hokusai VTE, and then a post hoc analysis of the 2 RECOVER trials suggest that DOACs are very appropriate in cancer-associated DVTs or PEs. So with that, sorry to take your time, but just to summarize, these drugs have a favorable pharmacokinetic profile. They're approved for a lot of indications. They don't require monitoring, but then they can't be monitored if you want to. Now they can be reversed. This was the big thing. Everybody said, oh, we can't reverse it, we can't reverse it. Now we can reverse it. And stay tuned for expanding indications. Who knows what's going to come up. And with that, thank you very much.